floor muscle training, which we are talking, may take a lot of time to get some benefit for them. But the more they know they are going to cough or sneeze, or they're going to bend down to lift some weight, if at that same time they do a little pelvic floor muscle contraction, they are able to avoid a not brace or do that. Useful in SUI. Next slide. Similarly, when we examine the patients also, we can make it and use that opportunity to teach them how exactly to do it. Next slide. Next slide. I follow this practice of asking them to stick bindi on their refrigerator, on their stove. Mobile, because mostly all of us give an excuse for not doing exercises when we don't have time or we forget. So if integrate this pelvic floor muscle training along with their daily work schedule, they are able to build. Next slide. So bladder training. Again, there is a saying in Tamil which is a local saying. So patient with urgency also with an intent to avoid they keep having urine very frequently every half an hour. In that way, what happens? The brain starts thinking that that is the bladder capacity and so you can ask them to increase the void interval. If you look into their bladder diary, you see them passing every half an hour. That week you ask them to pass every 45 minutes. And slowly you can increase that interval till you achieve a free avoiding interval of at least 2 to 2.5 hours. It's a useful frontline treatment. Other people, if you are going to only talk about so addition of anticholinergics also is useful. And got a lower level. So this I don't need to talk about all that. You have the tertiary anticholinergic as well as the Soliphenacin is now the UFI did a study and the prescription practices of urologists all over the country. And soliphenacin is the which is most used by the urologists now. Is a 90% agent, every antagonist, renewed selective, usage of 5 milligram, time to constipation, etc. To avoid urinary retention and fully control the erosion. Mirabegon is a new kid on the block. Beta the agonist, useful in bladder reducer relaxation and for adverse effects like rhino and compared to soliphenacin. But we have to be careful when we are using it in hypertensive patients, not more than 160-100. But only if the patient is well controlled on one drug, you can use it. Now, this is a question for the post lectures. Can you tell me what these studies deal with? Just to wake you up. The studies all study about the combination of soliphenacin with mirabegon. That is again the happening thing. Everybody, in fact, I put one scenario and the patients are started with 5 milligrams soliphenacin, no improvement 10 milligrams, then again I add back with mirabegon. All combination of soliphenacin and mirabegon. In fact, more non-urologists are using this. It is more efficacious and has got less side effects. Next slide. And this contact studies compared mirabegon and tadalafil versus tadalafil alone and found good results and combination therapy was used. Next slide. Again, we have a whole lot of newer drugs, imidafenacin, tadalafil, soliphenacin, mirabegon, and this tisnelefil, which is a novel PDE inhibitor, so it's not very useful. Next slide. In your recent advances, a lot of newer drugs are being tried. All what does it mean to us? We have still not won the game. We still don't know completely as to what is the problem. So we are going on experimenting. Next. Another, how to increase the drug delivery so as to improve the efficacy of the soluble botulinum toxin, like liposomes, lipopesicles, intravesical thermosets, hydrogens, DMSA, using protamine sulfate. Next slide. And even in the rats, etc., they try different approaches to increase the bladder permeability to instill drug molecules. like using electromagnetic drug administration and low energy shockwave, etc. It's very expensive. Next slide. So if you take the evidence based in the AV management, the most important is you need to counsel them on not only the success but the adverse effects. You have to prescribe the lowest recommended dose when starting, and that is the drug treatment is effective and well tolerated. You need not change the dose of the drug. And if you find that the first drug is not effective or well tolerated, you can change. But there is no use studying toxic, etc. for overactive bladder and avoid oxybutylate in frail elderly women. Next slide. There is no consistent evidence that one drug is superior to another for cure or improvement of the other incontinence. So whatever drug you are comfortable, you can use. The extended combinations are better in efficacy and lesser in adverse effects. Soliprenazine is more effective than tolterodine for improvement of urinary incontinence. And oxybutylate here shows higher rates of diagnosis than tolterodine. But whatever it is, daily in practice, we see more than half the patients will start antimuscarinic agents by 3 months, either because they found it not very helpful, or because of the adverse effects, or because of the cost. We don't see them taking it for a very, very long time. And again, when you compare drug versus non-drug therapy, there is no consistent evidence to show superiority of the drug therapy over behavioral therapy for treatment of urinary incontinence. And behavioral treatment has higher patient satisfaction than drug treatment. And there is no consistent evidence to show superiority of drug therapy over pelvic floor muscle treatment. So all these have to say the initial aspects, whatever we said, like weight reduction, pelvic floor muscle training, bladder training, all that can be really tried for a long time. Next slide, please. If the patient, then we go to the third one, botulinum toxin intradetrusor. Next slide. Sacral nerve stimulation and posterior tibial nerve stimulation. These are all coming up really earlier. It was only done in very few centers, but now we are having this for refractory OAD. Next slide. If the patient really refractive to anything, we can do this augmentation system plasticity as a last resort. These are the new guidelines for EAU 9 and EAU guidelines which talk of behavioral therapies, antimuscarinics, and urodynamics only if it doesn't fit into it, then background, and then you go into the last parts. Next slide. So I just again to break the monotony, the common scenarios which we have. Widow, obese, diabetic, bilateral osteoarthritis, pregnancy and incontinence is 87 kg. The investigations were all done. High sugar levels, and then she was stabilized, and then after she's normalized, some frequency came down. Ultrasound and post-void residue is very, very important in a patient, especially a diabetic, because again, question to postgraduates. We are dealing with urgency, urgent incontinence in a diabetic patient who is not becoming all right. Is there a role for doing ultrasound and post-void residue? So what will you see? See, you will see increased post-void residue. That may be the reason for her. So there is no point in putting her on anticholinergics if there is an underactive detrusor. But if there is no so Bhargavi, the first pen can be got by him. Thank you. Excellent. எவ்வளவு வேணாலும் சந்திரன் வாங்கி கொடுத்துருவாரு. எல்லாரும் ஆன்சர் பண்ணாங்க. நான் இன்னும் முதல்ல கேட்டது எதுவுமே வரலையே. So weight reduction is very important. Pelvic floor muscle training. Of course, in the elderly, it may not be possible to do, and it may not be very effective. If there is no increased post-void residue, with a combination drugs. Next slide. In the elderly, avoid bladder irritants like caffeine, tea, and soda. Keep pathways clean and bathroom clutter-free. with lights on at all times. We need to be careful on power spending, but at the same time, our women, our grandmothers, or even us at our age, we must not sustain falls and fractures. So there must be some light even in the night. Make sure you provide regular bathroom breaks. This is for the entire population, I'm saying. Use underwear that is easy to get on now. Use absorbent underclothes for trips away from home. Using diapers is not a shame. Supportive caregiver. Because why I kept on emphasizing, I have seen patients who, for the fear of being, criticized by their own people, landed up bedridden with falls and fractures. Okay. And then scenario two, a 45-year-old lady came to the OPD saying that she was suffering from recurrent UTI. And we have taken multiple courses of norfloxacin, oxide, and alkalinizing syrup, and she used to feel comfortable. She was given that once or twice by her doctor, and she kept repeating the prescription again and again. And then she had markedly increased urinary frequency, urgency, frequency amounting to incontinence. And even she did not get relief. Now her people added sulfasalazine to her, not medical officers, but they added sulfasalazine. And if that didn't improve, her medical staff person suggested you go. Nowadays, I'm the urologist, sulfasalazine mera background எழுதுறாங்கம்மா அதை வேணா சாப்பிட்டு பாருங்க. Now, again to my dear postgraduates, what is in your mind? நீங்க ஆன்சர் பார்த்து சொல்லக்கூடாது, அடுத்த ஸ்லைட்லாம் பார்த்து சொல்லக்கூடாது. Even now, what is in your mind? Do you want to give any differential diagnosis, or do you want to evaluate in anything is ringing in your mind? GUTB, yes, very good. Second pen also to him. Barclay, excellent. So the patient came with a single bladder. So much so, actually the dysuria, urgency were all symptoms of GUTB which was missed. And finally, she came in this stage when an augmentation cystoplasty had to be done. So all frequency urgency dysuria are not urinary tract infection, and giving sulfasalazine and mirabegron, of course, it's not for us. We are going to evaluate and treat, but we have a whole lot of pharmacy drugs which are being given. They tell மீரராகவன் மேடம் இதான் எழுதுவாங்கன்னா அந்த அடையார் ஏரியா எல்லாமே அந்த ட்ரக் போகும். This patient came to me recently. A 46-year-old Paris lady referred with complaints of new onset urgency and a profuse watery discharge. She is a known case of fibroid uterus. Software சொல்லுவாங்கல்ல, unnecessarily we don't want hysterectomy and the patient. But now suddenly she is worried about urgency and a profuse watery discharge. Again, she was given sulfasalazine by a doctor who referred to me, but she had no relief of symptoms. Again, can you think? In fact, that patient gave me permission to take a clinical photograph. I couldn't retrieve it from my phone. Again, anything in your mind? Anything? Anything else now? Fibroid is coming out into the vagina. When I saw her, such a big fibroid, gorilla size fibroid was sitting in the vagina. Long ago, they have done ultrasound, so she's been there with that fibroid for a very long time. Now it has started coming into getting extruded. And people, once they know it's a fibroid, they know no bleeding. That was not in the mind. Clinical examination was missed, even by the referring gynecologist. They could have seen such a big myoma, submucous myoma, extruding into the vagina. So big. In fact, I called the husband and asked him to see, and I to ask permission to take a clinical photograph. I couldn't. Arrange for the you can see it coming out nicely. Okay. So urgency and urge urinary incontinence in women can be anything because of OAB, menopause, pelvic organ prolapse, vaginal birth, hysterectomy, mass, any mass. or a neurological disorder like multiple sclerosis, Parkinson's, diabetes, stroke, even diuretics, obesity, smoking. So it only warrants that next slide. Urgency is a symptom like fever. We need to really evaluate. A good history taking is very important, and patients need to be methodically evaluated. Appropriate multidisciplinary management whenever necessary, a positive attitude, environmental manipulation, especially if we are taking care of the geriatric population, we are sure to achieve the best outcomes. Is right? And the goal is to make a prediction. Yes. Lady continent. Next slide. So we need to achieve freedom from incontinence, need to cure incontinence, keep patient comfortable, prevent discomfort, prevent complications. If you are not able to do that, in spite of all your things, asking her to use diapers is not a shame. We don't want that woman to suffer. That's all. So it is not a shame. But of course, after evaluating her for everything, if you can surgically correct, there is no harm in operating on an 86-year-old lady for SUI. Of course, the guidelines say if you operate on obese women, operate on elderly, the outcome is less. They want to safeguard themselves. But believe me, in well-evaluated patients, you can give them good quality of care. There is nothing to be ashamed of. So we ultimately need freedom from incontinence. Right? So, my dear postgraduates, please scan the QR code and start answering. You have a, it's also activity based. You have a prize. இது வந்து யார் ஃபர்ஸ்ட் ஆன்சர் பண்றாங்க இது யாருக்காவது வரலன்னா அடுத்த ஸ்லைட் will be a Google link. நீயும் போட்டுக்கலாம். Very good interactive session. Really appreciate. Thank you so much. I have questions, sir. Thank you for the excellent lecture. This is the review of present congress. Thank you, madam. Mr. Always explaining, madam. One small thing I would like to ask about practitioners and the recent thing which has come into this Turniva and they have started to make so they are promoting this for mild SUI also the ultrasonic transfer. Your experience with that for many cases you have very. The result is really good for the menopausal symptoms of strong good. But for military incontinence, you do not have, you are waiting for very good evidence. And whatever minimal SUI which they are trying can be benefited with pelvic floor muscle training and exercise. If you carefully look into their guidance, they don't attribute these people to who have real severe incontinence. They only talk of mild incontinence. Most of the mild incontinence, if you really give them a physiotherapy and weight reduction, they are better. So I don't. Yes, sir. The reason for that is they don't know the job. Yes. Most of them lots of the exact cost of poor people. That's why we have only drugs are coming. Modulation, pure modulation. As you said, nothing is perfect in it's a Thank you, sir. Thank you for your excellent presentation. I request Professor Rajaram sir to form an opinion. In case ಯಾರಿಗಾದ್ರೂ QR code ಬರಲ್ಲ, I have a Google link also, but I think it's Madam, any number of times you can get it. She's worthy of it.